Hi, I'm Dr. Brad Knight, the director of the Heart Rhythm program at Northwestern for the past 15 years. There's been dramatic changes in our field just in the last year with the availability of pulse field ablation as a new energy source for catheter ablation, primarily for atrial fibrillation. And with this new technology and all the rapid changes that have been occurring, there's a lot of talk about efficiencies. And we've strived to be as efficient as possible, but I want to spend a few minutes talking about what that means and how that's changed over the past several years. PFA has allowed us to now focus on efficiencies. But what does efficiency mean? Efficiency is accomplishing a task with fewer resources or in a less amount of time. And that's been a goal of ours. It's different than efficacy or effectiveness, which are the, bare minimum standard is to be effective in the procedures that we do. And it's different than the word proficiency, which is really performing procedures with an expert manner in an expert fashion. And that's ultimately the goal, is to perform procedures in a proficient manner. I trained at the University of Michigan in the early 90s with Dr. Fred Marotti, and our early work was very devoted to being more efficient in the EP lab. Fred Marotti was the most efficient person I ever worked with. He was never in a hurry, but he never wasted a moment of time. And was very interested in ways to save time without negatively impacting efficiencies. We would put sheaths in the holding bay and the femoral vein before the patients would come into the EP lab. But for example, there was an early study looking at giving 4 extra stimuli when performing ventricular extra stimulation, as opposed to the sequential fashion where we gave 1, 2, 3 extra stimuli to perform risk stratification in patients with coronary disease to see if they needed a defibrillator. And that new technique really became widely adopted around the country as a way to be more efficient. Some of the early work I was involved with was coming up with very efficient ways to make a differential diagnosis of supraventricular tachycardia in the EP lab. SVT has a broad differential diagnosis, but pacing maneuvers and observations can be done in a way to make that procedure as efficient as possible. So I've tried to bring that to our team here at Northwestern for the EP program, is really focusing on efficiencies. And so why does this matter? Well, it matters for 2 reasons. One, being efficient in the EP lab is good for patients, primarily. There's data that when patients are undergoing device implantation, efficiency is important. The longer the pocket is open, the higher the rate of infection. For catheter ablation, there's data that there's a direct correlation between the amount of time a patient's in the EP lab and the number of complications that a patient can have. So it's important from a patient perspective. It's also important just from a resource standpoint. EP lab time is highly valuable. Anesthesia time is highly valuable. And as the PFA volume has dramatically increased in the past year, at Northwestern, we've had a 44% increase in our AF ablation volume just since the prior year. This has made it difficult to get cases in, and efficiency matters from that perspective. But what about the other side of the coin? What if you're striving too hard to be efficient, and what are the negative downsides to doing that? Well, one is there's some fundamental things that have to happen. And so if you're spending too much time on being efficient, it can actually increase complications. Some things are very important, but do take time. For example, talking to the families after the procedures takes a little bit of extra time, but it's a required part of what we do. And there also is this concept of an observation period. So when we do an ablation procedure for an accessory pathway, for example, we wait about 30 minutes to make sure it doesn't recover from the RF ablation during the observation period, and make sure we don't need to go back in and do another ablation procedure. So there's the one side of this, but I think the most important thing is to operate kind of at the top of the efficiency curve to optimize outcomes. So how do we do that? One approach is to work in variable speeds. I like the analogy of a variable speed drill. We can go slowly when it's very important and we're performing a critical aspect of the procedure, like a transeptal puncture, or at other times when we're prepping equipment, we can go at high speed. So being able to go from low speed to high speed and back and forth is a way to save time in the EP lab. Another consideration is trying to not ever be at a standstill so that when you're checking a pacing threshold, you're also starting to tie down the pacing lead. So not missing any opportunities to get some work done in the EP lab during a single procedure. What about specific examples? I talked a little bit about efficiencies in the EP lab with ventricular extrastimulation, with pacing maneuvers for SVT. But one consideration that we've really strived to do is to minimize the numbers of catheters used. So an SVT ablation can easily be performed with just 3 catheters from a single femoral vein. So we try to minimize the number of catheters used. With PFA now, for a patient who comes in with paroxysmal atrial fibrillation and who comes in sinus rhythm, we often only put 2 catheters in. A transeptal catheterization from the right femoral vein that allows us to exchange that for a delivery sheath into the left atrium for the ablation tool, and from the left femoral vein, an intracardiac echo catheter. We no longer place a coronary sinus catheter. We don't need a His catheter, an RV catheter. So minimizing the numbers of catheters is important. There also have been some incredible advances just over the last few years that allow us to be more efficient. One example is the improvements in imaging. So we have been early adopters of intracardiac echo, using it to guide transeptal puncture. It's become very clear that with PFA, contact is important. So having ice either in the right atrium or sometimes in the left atrium to get optimal contact guided with ice is important. So imaging has really improved over the last few years, helping make us more efficient. High-density mapping has improved. The ability now with these multi-electrode high-density mapping catheters to generate an electroanatomic map of the left atrium during a flutter, for example, within a few minutes has really revolutionized EP rather than point-by-point recordings of electrograms to generate a map from an ablation catheter. So that really has improved the efficiencies of what we do. Over time, we'll have ablation catheters with PFA that will also serve as mapping catheters. So that will continue to improve efficiencies and lower left atrial dwell time. On the other hand, there are times when a high-density map isn't even indicated or needed. So if you have a patient with persistent atrial fibrillation who converts to atrial flutter, a lot of times you can deduce that with some pacing maneuvers that it's mitral isthmus-dependent flutter without having to do a whole new map. So coming up with ways to strategically save time during the procedure is important. Transeptal catheterization itself has become much better, much more efficient, much more safe, and that has also reduced procedure times for AF ablation. In the past, it was a mechanical needle with other catheters in positions, such as a pigtail in the aorta to give us a fluoroscopic reference. We now have catheters that can deliver powered energy through the needle tip, or more commonly now, powered wires to perform transeptal catheterization guided with intracardiac echo. So this has really improved our ability to effectively perform AF ablation with these new PFA tools. We adopted cryoballoon ablation about 15 years ago as our preferred method of isolating the pulmonary veins in most patients with atrial fibrillation. And that proved to be significantly more efficient than point-by-point radiofrequency ablation. And it is true that over the last few years with high-power short-duration lesions and with contact force and other improvements, ablation indices, for example, RF ablation, point-by-point ablation did become more efficient, but that was an example of adopting a new technology early that helped our efficiencies. With PFA now, there are now 4 FDA-approved PFA tools. We've also have a lot of experience with other investigational devices. So we're very excited about the opportunities to not just take advantage of the PFA catheter itself to be more efficient as an energy source, but also to come up with additional strategies that will allow us to be more efficient while being as or more effective and as or more safe for patients. Thank you very much.